So thank you very much to Steve and Jerry for inviting me to speak. I have to say, I did think to myself, I'm a psychiatrist, right? Are you sure? And anyway, I thought it's good actually, because we can do an exchange. I'll get my chronic back pain looked at, and someone here can get a mental health assessment on a relative of their choice. Anyway, so I'm going to talk a little bit about equality and diversity in education. I am a doctor, so this is from the medical perspective, and it will hopefully give you some understanding of what things are like in medicine. And first of all, actually, really, I need to just make sure that we're all on the same page. And, whether we like it or not, I mean, I grew up, I'm of an age where I grew up with Sesame Street and, Play Away and Play School. And the whole of Sesame Street and Play School, etc., were all about everyone's the same. Everyone's the same. There's no difference. So we grew up with the feeling that, isn't it lovely? Everyone's the same. But the reality of the world is, whether we like it or not, there is a social hierarchy. And that social stratification, our position in society, actually affects a number of things. But from my perspective, and actually should be also from yours, because you're health practitioners as well, is that it affects people's health. And your position in society will affect how you are differentially exposed to or vulnerable to risk factors for later ill health. And you will know better than me that one of the leading causes of days off work and early retirement is chronic back pain, for example. Other leading cause, mental health problems. So does it matter that you might have worse health later on in your life? Yes, it does. It does, because even if you don't care about the individual, care about your tax dollar, if you like, or your tax pound, because you will be paying for people who are unable to be productive because their health is poorer. Your position in society affects your standard of living. It affects the kind of community you live in, the neighbourhood you live in. It affects the kind of adverse risk factors that you will be exposed to, or protective factors that might mitigate against those adverse risk factors. It even affects the kind of health behaviours that you have. So, for example, there's a thing called the poly pill. As everyone gets old, physical illness is, if you like, a problem of older people. As you age, your body, deteriorates. You're much more likely to get heart disease, etc. And we know that the things that help are, not being obese, eating healthily, exercising regularly, and so on. It's been shown that if people over the age of about 50 take something called the poly pill, it contains a statin and, aspirin, a blood thinner, etc., that you can have, it adds about 5 years to your life expectancy. So, of course, when that information came out, what happened? All the middle class people who exercise regularly, eat healthily, don't drink too much, all rush to their GP to get the poly pill. But they're not the people whose life expectancy is really going to be significantly impacted by the poly pill. Well, a little bit, but actually, really, the poly pill is much more likely to help those people who don't do the exercise, who don't eat healthy, and so on. And so that's an example of how, if you are already middle class educated, etc., then you're going to have health-related behaviours that are probably more conducive to a longer lifespan. It also, interestingly, your social position in society affects how your body reacts to the adverse or protective factors that you may be exposed to. I don't have time to go into that now, but there's more and more robust evidence that the way in which you are treated does actually have an impact on your body. So I'm sure you've heard, you've read about how trauma can affect people, and not just in their mental health, but also their physical health. Anyway, essentially, your position in society affects your distribution of health. And that's not just me saying that. That's not some left-wing think tank saying that. That is Public Health England saying that. And I would urge you to look at Sir Michael Marmot's work. Michael Marmot has written huge amounts about this, and he has come to the conclusion, it's not, and I met him a number of times, spoken to him a lot, And Michael Marmot says, this isn't an ideology. It's taken me a few years. I've done all the research, and my clear conclusions based on all the evidence is that poverty leads to poor health outcomes. Anyway, so this is a graph of, or there's two graphs actually, two charts. And these are charts of income and deprivation according to ethnicity. So what I want you to look at on the left-hand side are the blue bars. So these are medians. These are average kind of wealth. It's average household wealth by ethnicity. Okay, and at the bottom are the people who are richest in our society. So if you could see this very closely, this says average household wealth £300,000. Now that doesn't mean to say that's what people have got in the bank. That's including, you know, all their assets, their house, and everything else. And at the top are the poorest people in our society who have, on average, total assets of less than £50,000. Okay. The reason I'm showing you this is that I don't know if you can see this so clearly, but at the bottom here are people who have a head of the household who's from a white British background, and at the top are the poorest people, who are people who are from Black African background, any other ethnic background, Bangladeshi, Chinese. Why is that important? It's important because we have a tendency to lump everybody together. Black, white, Asian. What you'll see, if you can have a look here, is that matching the total household wealth of the white British people at the bottom here are people who are Indian, so that's South Asian people of Indian background. If you look at the top here, you've also got South Asian people. These are some of the poorest people in our society. South Asian people of Bangladeshi background. Now that is really important because, interestingly, when you look, so this became very apparent during COVID. During COVID, it became clear that people from minoritized ethnic backgrounds had much worse outcomes with COVID, much more likely to catch it and die. And that was to do with various factors. Certainly in health, it was to do with the kind of work that people were doing. And when you looked at it a bit more close, when people looked a bit more closely, found, oh, the Bangladeshi people are doing really badly. In fact, let's have a look at the Bangladeshi people's health generally. Bangladeshi people's health is pretty awful. And the question is, what's going on? Well, if you were in the 1980s, 1 in 20 Indian men was a doctor in the UK. And that was because, for the most part, Indian doctors were being encouraged to come to the UK to work because there was a shortage of doctors, which is what we have right now, actually, interestingly. More on that later. Indian doctors were being encouraged to come to Britain to work. And they did. They came thinking, great, I'm going to go and work in one of the, gold rotation teaching hospitals in London. Didn't necessarily get those jobs, might have had to go and work in a much smaller place, I'm trying to think of somewhere that's not going to upset anyone, but let's say they had to go, work in Wadi Range, which is where I'm from, which is small and certainly not, in any way salubrious. And so that they may not have been able to work where they wanted to, but I can tell you now, in the NHS, everyone gets paid the same. So they would have come, they would have had a good income, no matter where they worked in the country, and that income meant they would be able to, pay their rent, buy a house, pay the mortgage, send their kids to nice schools, and so on. Unlike people from Bangladesh, who around the same time were coming to the country, mostly escaping war, famine, and flood. So a lot of people actually coming with very little money, and in fact, in some cases, coming as asylum seekers. And that's a very different type of immigration. In addition, there are cultural differences as well in terms of how people are within their families, but nonetheless, those differences in wealth have persisted. On the right-hand side, we have, anyway, the point about that is that actually the success, if you like, of the Indian group masks the ongoing difficulties in the Bangladeshi group or the other group. And in fact, same for Pakistani people as well. On the right is a graph looking at deprived neighbourhoods, and it's looking at ethnic populations living in the 10% most deprived neighbourhoods. And it's on the right-hand side. These are the people who live in the where you've got the majority of people, the highest proportion of people living in a deprived area. And you can't see this, but at the bottom here, it's by ethnicity. The biggest group here, Pakistani people. So 1/3 of Pakistani people live in a deprived area. Then it's Bangladeshi people. Then it's Black Caribbean, Black other, Black African. The people with the lowest proportion living in a deprived area are people from Indian backgrounds and then people from white British backgrounds. Why is that important? It's really important because if you are from a poor background and live in a poor area, you will spend 1/3 of your life in poor health. If you are from an affluent area, live in an affluent area, you will spend 1/6 of your life in poor health. That's half the amount of time. So, for example, with the kind of patients that I have, their life expectancy can be reduced by up to 15, 20 years because they might have a severe mental illness. Now, what that means is that, and in fact, there are differences in people. I mean, you know, if you happen to be lucky enough to be a South Kensington person, for example, very rich, and you get all the accoutrements that go along with that, you know, let's say your average life expectancy is meant to be about 80 if you're a man. Yeah, this is general population, not my patients. But if you've got general population, your life expectancy is 80. If you live in North Kensington, sounds nice, but in fact, it's really quite a poor area and it's very deprived. It's only 1.5 miles up the road. Your life expectancy is 5 to 7 years shorter than if you live down the road, which is quite something. And get this, that, you know, instead of dying at 80, you'll die at, call it 75. And 1/3 of that 75 years will have been spent with, you know, asthma problems and breathing problems and heart problems and going to the GP every week and then having to go to going to the hospital to have dialysis and so on and so forth. So, I mean, 1/3 of what, 30 to 75, let's call it from when you're in your early to mid 50s. I mean, you know, I know you can't believe this, but I'm in my mid 50s, and the idea of having to go and have dialysis every week, or not really being able to function, not really being able to, it's very difficult. Your chronic disability starts then. Unlike the guy from South Kensington, whose chronic disabilities, his dialysis, etc., wouldn't start until he was in his mid 60s, good 10 years later. Okay. Also, interestingly, for the point of this talk, it turns out that number one, your ethnic background does affect, you know, how poor you are, but it's not simply about how poor you are, because doctors, I mean, doctors come from all sorts of backgrounds, but eventually, because we all get paid pretty well, certainly when you get to be a kind of relatively senior doctor, we're all, you know, we're not poor. But weirdly, your ethnic background will affect your outcome in medical training. Okay, so what might that be about? Because if it's not about poverty, then is there something else going on? I'm just going to talk a bit about different types of discrimination, because I think everyone understands what discrimination is. You know, it's this, isn't it? Especially this is racial discrimination. Do you remember when it was, this is the Euros, and this is Saka just after he missed the penalties, and he was absolutely lambasted. You know, people were booing and hissing and everything else. But also there was a section of the crowd that were monkey chanting and throwing bananas at him and stuff like that. And it was really awful. And there was uproar and everyone said, isn't that terrible, awful, we're not like this. And this is what we understand about racial discrimination. It's that horrible thing that people do when they spit at people in the street or punch them or say nasty things to them. And of course, one of the very worst things you could be in this day and age is a racist. Absolutely horrendous. Terrible thing to call someone. And I think the only thing that you could, you know, someone call, a worst thing to be called would be a paedophile, or, you know, a racist paedophile. That's the only thing that's worse. And the thing to know about, you know, these acts of racism is that they do have an impact on people. It used to be thought, well, you know, you just have to suck it up, but actually it does. It's pretty clear now that unfortunately it does have it does take its toll on people. It has a negative emotional response. It's essentially, it's like, you know, it's a mini trauma. It can create sadness, anxiety. It even has there's a physiological underpinning. It's a stressor. And, you know, for some people over time, unfortunately, that it's been increasingly shown that can be associated with longer term negative effects on their mental health. Anyway, we all understand that kind of racism. That's what we think. When people talk about racism, that's what we think they're talking about. But there are other types of racism as well. And increasingly you'll hear about this one, you know, institutional or structural discrimination or racism. And institutional discrimination is when there's a differential access to goods and services and opportunities by race, sex, gender, religion, disability, etc., whatever protected characteristic a person may have. This is something you can't help about yourself, something you might just be born with, that people can discriminate against you for. Bear in mind, we all have prejudices. You know, we can't help it. We're all brought up in certain environments, etc. And your prejudice is something that you may or may not be aware of, actually. However, if you become aware that you have a prejudice, then you know, the thing that you need to do is to try your hardest not to discriminate against someone. So you have your prejudice, which will be the negative assumptions that you make about a group of people and an individual from that group. The discrimination is when is the behavior that you show towards that person about whom you may have prejudice. So and the, you know, for example, which I should admit to a prejudice. When I was, I'm going to have to be careful here actually, but when I was growing up, I have to say that I always used to think, I don't really like really. Anyone here from Texas? No. Anyway, do you remember Dallas? And there used to be a program on called Dallas, and there was JR, who was the hated figure, and he had a really strong Texan drawl. And it's interesting that I realized that when I was hearing that Texan drawl, I was thinking, this person's clearly a bad one, you know. And I realized when I got older, this is a prejudice based on, you know, what I thought JR was like, etc., etc. So I had to work quite hard, especially because I now have really good Texan friends who I met through my kids' school, and we go on holiday together. And it took me, I mean, it was only then that I realized, whoa, because, you know, they're in America now, they come over, and when they come over, they're really loud. You know, and I have to say, you know, but I don't discriminate against them for it, because I recognise my prejudice, and now we're really good friends. Anyway, I've got really good friends who's Texans, so sorry. Anyway, the point about institutional discrimination is that it manifests as a inherited disadvantage. There's a sense that somehow it's kind of codified. We're just so used to it. So maybe a way to explain it is this. Years ago, 150 years ago, the person giving this lecture, Dr. Smith, would undoubtedly not be a woman. Just could not be a woman, right? Everyone's nodding. We all know that. We know that to be true. And we know that to be true. And obviously, it couldn't have been a woman, because 150 years ago, it was very well known, scientifically proven. There are articles in, you know, some of the best journals in the world at the time by some of the most eminent scientists that if women were educated to any high degree at all, our ovaries would shrink and our brains would boil. It was just known. Everybody knew. So, of course, you know, if you're, you know, mummy and daddy, you just had your little baby, Angelica, little girl, isn't she gorgeous, blah, blah, blah. You go to the Victorian version of the NCT coffee mornings. And in the NCT coffee mornings, you know, your friend who's on her third or fourth child, you know, you're saying, oh, look at my lovely little Angelica, isn't she gorgeous? I hope one day she'll be like her daddy, she'll become an engineer. And your friend, who's well versed in these things and knows everything, says, oh, no, you've got to be really careful. And explains about all the scientific theories and everything else. And you're like, oh, okay, fine. Shoot forward a few years, Angelica's 8 or 9, and she's absolutely adores her daddy. She runs up to daddy, when I grow up, I want to be an engineer like you. Shock, horror. Dad says, oh, no, darling. No, Angelica. Just needlepoint for you, because daddy and mummy are such good parents. They care about little Angelica. They care about her ovaries. They want to be grandchildren. They care about her brain boiling and her becoming someone who sits in the attic like Mrs. Rochester. You know, they were just doing what was known to be right. And after a while, everyone forgets about where the idea came from and the scientific evidence. You just know, oh, no, you don't educate women. It's just not the right thing to do, is it? And gradually it becomes the thing that everyone knows. It becomes codified into our customs. And then when Elizabeth Garrett Anderson, you know, one of the very first female doctors, writes to the medical school and says, I would like to join your medical school. I'm very good with my letters and numbers. You can imagine they rolled around laughing, and some of them were just affronted. Who does she think she is? This woman, an affront against society. How dare she? Does she not know that her becoming a doctor will degrade the fabric of our society? This is unbelievable. Unbelievable. After a while, this kind of institution, I mean, just to say, it became very clear that to get into medical school at that time, you had to be a man. So the institution put in some policies that made it very clear. I mean, actually, they didn't even have a policy for it at the time because it was like, we don't get it. So when she started to write to these medical schools, then they put in a policy, no women, can't have women, which seems fine, except for the fact that women at the time needed other women to provide them with good medical care. And women could provide medical care as nurses, but of course, nurses didn't get the same training. Also, the men who were doing the doctoring and doing all the science and everything were thinking about the research that they need to do, thinking about what the problems were. And of course, you know, when you study medicine, I'm sure it's the same for you, oftentimes it's clinical observation will drive the research that you do. When you see that there's a problem, then that's when you start to investigate. And the blokes doing the doctoring could see that there's a bit of a problem here, that there are men who aren't able to be fertile. There are men who have problems with you know, walking, whatever, but they wouldn't be thinking about the women who might have problems. You know, they might be thinking about women who have problems getting pregnant. They might not be thinking about women who have problems with their periods or the menopause or endometriosis, things like that. Why is that important? Because even today, there are clear differences in the health outcomes of women that can be linked to the delay in women, actually the women's research and women actually being doctors. So, for example, we know that if you look at diabetes, so outcomes for diabetes in women are much worse. So if you get, you know, diabetes, you can get various complications. For the same complication as a man, woman has 4 times worse outcome. So the hazard ratio for a woman is much worse than it is for a man. And that's because for the most part, a lot of the research was done on men and then extrapolated to women. Okay, so does it matter? Actually, yes, it does. This isn't to say that people were, you know, it's not like in Elizabeth Garrett Anderson's time. It's not to say that nowadays people are kind of deliberately saying, we're not going to offer you a service because you're a woman, right? Or anything like that, or because of your race or anything. There's often no active perpetrator. It's just assumed that's how things are. So in my profession, there are really high rates of Black people who end up being detained under section, 4 times higher than you'd expect for the general population. And people just look at it and say, oh, yeah, you know, because everyone's so used to it. But what hasn't really been asked, and we're now asking the questions, but what wasn't asked for a long time was why. It was just assumed that that was how it was. It's inaction in the face of need. And that's what you need to be thinking about. All right, so who's missing from the space? Does it look, you know, I mean, I have to tell you now, I'm sort of thinking it's interesting because I hadn't thought about, you know, an osteopathy university and what the makeup might be. But it's interesting, as I'll tell you later, that if I think about doctors, half of medical graduates now are from an ethnic minority background, which is a lot, actually. if I was sitting in the School of Pharmacy up in town, I suspect that the audience would be more than 50% ethnic minority, actually. So I would say to you, who's missing from the audience? So the question then is, why is that? Anyway, just to say something about policies and how they can unfortunately cement in discrimination. And again, it's about just understanding how, without realizing it, sometimes you can make a decision, make a policy, and unfortunately it can really disadvantage a whole group of people. So the one baby policy in China, you remember that many years ago when China was not the superpower it is now. It was very poor. There was famine. Lots of people were peasants working in the fields, etc. And they just had too many people, and they were starving actually. And the government, probably quite sensibly, if you think about it at the time, said, do you know what? We cannot sustain this population anymore. People are dying. We're going to have to do something. And what we're going to ask you all to do is only have one child. And people are like, really? And said, yeah, well, if you only have one child, then we might be able to sustain our nation. Anyway, what they didn't think about at the time was that people were thinking, well, if I can only have one child, I better make sure it's a male child. Because if I have a male child, then that male child will get married, have kids, and they'll all come and live with me, and we'll have more people to work in the fields. If I have a female child, that female child's going to live with somebody else, and then we're going to be in our dotage and we're going to die. There's going to be no one to help us. So what people did was to make sure that they only had a male child. If they were having one child, they would only have a male child. And they did that in the various ways we know people can do. And in fact, there'll be some of you, I'm sure, who have friends who've adopted children from China. Every single one of those children will be a female child. Yeah. What that's resulted in is, so there's a guy called Amartya Sen, he did some work on this, and he looked at it and he thought, you know what? Because on average, when you look around the world, on average, it's on average about 50% male, 50% female in most countries. Just a natural birth rate tends to happen like that. And what is found is that in parts of mainland China, there were an estimated more than 50 million women missing from the population who should be there. And in certain provinces, because this was particularly prevalent, it means that there is such a large number, it's a bit like Alaska, loads of blokes, not many women, to the extent that the men aren't able to find partners to get married. And so there were families that are dying out as a result. And, there have even been, reports of women being kidnapped to help keep the family going. The Chinese government didn't plan that. It's not useful. It was an inadvertent result of a policy that they put in place that disadvantaged and discriminated against a whole group of people, in this case, women. There were some more, more obvious ones, like the White Australia policy, basically, to expunge Aboriginal, native Aboriginal culture from society. The segregation in Northern Ireland, we know about. Obviously, apartheid in South Africa, that's a really obvious one. And there were some that are deliberate and some that are inadvertent, is the point. But these are examples of structural policies that result in discrimination. And then there's this kind of discrimination. Okay, so this is perhaps the hardest one for people to have to think about. It makes people feel a bit uncomfortable. But essentially, I don't know if people have heard of this thing called the doll experiment. Right. So the doll experiment. This is in the 90s. This is thinking. Remember, this is kind of in the 1940s and 50s. America was segregated society, and there were these couple of psychologists, Kenneth and Mamie Clark. And what they did was to take a group of primary school kids, a group of white primary school kids and black primary school kids. And they gave them each child was given a doll, a black doll and a white doll. And they were asked, which of these dolls is the clever doll, the funny doll, the doll that the teacher likes, the doll that people want to be friends with, the doll that's going to do well in life? Which of these dolls is the bad doll, the naughty doll, the doll that's going to get told off by the teacher, the doll that's stupid and that no one wants to know? Okay. So when they gave the dolls to the white kids, they said, okay, which doll you want to be friends with, the kind doll, etc. And the white kids said, oh, obviously the white doll, and pick the white doll. when they asked the black kids the same question, which doll is the funny doll, the clever doll you want to be friends with, the black kids all picked the white doll as well. Okay. And Kenneth and Mamie Clark said, look, everybody is brought up in the same society. We are all brought up with the same messages. And in those days, there were very clear messages, you know, no coloureds, etc. We are all brought up with the same ideas and mores and thoughts about different groups of people. And that affects everybody. And they said that essentially what happens is that those messages are internalised. And they're internalised such that if you are from a minoritized ethnic background, maybe you'll accept the assumptions that are made about groups of people like who, you know, the group of people that you're part of and the stereotypes. And maybe you'll accept what people are saying about your abilities and your intrinsic self-worth, that it's not really worth that much as someone else in a majority white population, for example. And unfortunately, that internalization can result in people devaluing themselves. So in parts of the West Indies, not just parts, in the West Indies and in India, you'll often get stratification by colour. So the fairer skinned you are, the more valuable you are as a person. To the extent that people use bleaching creams to make their skin lighter, which is dangerous actually, because bleaching creams are really bad for your health and give you cancer and things like that. Maybe it can just involve more kind of subtle things. What's the point in bothering? I'm not going to amount to anything anyway. So you just, you know, kind of get resigned to your fate, drop out of school. Why bother to vote? Doesn't mean anything to you. Maybe you get more engaged in risky health behaviours. So on the left-hand side here is Jane Elliott, and she's a primary school teacher. Again, she was just teaching her kids about, you know, discrimination and what it meant. And she did this thing called the blue eyes, brown eyes exercise. Now, I'd urge you to look it up properly, but essentially, she said to the, you know, usually always in favour blue-eyed kids, you're not in charge today. The brown-eyed kids are in charge. And so the brown-eyed kids became in charge. By day 2, in fact, I think by the time it was late in the day when it was, you know, lunchtime, the blue-eyed kids were, instead of being rambunctious and jumping around the playground and getting involved in the games and deciding what the game was going to be, they were sitting on the benches and being a little bit forlorn, a little bit out of it, a bit withdrawn. By day 2, the parents had said, you know, yesterday little Johnny was happy-go-lucky, confident Johnny, and now he's kind of lost all his confidence. You might stop this thing, please, because even his work's starting to fall off. Within a few days, there'd been a dramatic change in how these children saw themselves. Anyhow, so discrimination. I mean, you know, there's definitely evidence now it's a risk factor for mental disorder, but I just wanted to be clear that you understood the different types of discrimination. 3 main types. There's that interpersonal, you know, personally mediated, you know, discrimination or racism that we all know about. There's the institutional and structural stuff that's so subtle. We're all involved in it. You can't see it. And it's often not deliberate, but it's inadvertent, and it's that inaction in the face of need. And then there's the internalized stuff as well. Okay, so very much finally at the end, finally gets another bit. Now this is about education finally, and I just wanted to show you this because this shows you the this is a proportion of 18-year-olds going into higher education, and this is by ethnicity. And if you're above this line here, this means that you are underrepresented in higher education. This red line is actually white kids, particularly white boys actually, who are far less likely to go into education, funny enough, than Asian kids, black kids, mixed kids. And the kids most likely to go into higher education and growing are children from Asian backgrounds. Great, well done them, black kids. Anyway, now this is a pathway to kind of career progression for doctors. And this is, you know, thanks to Anton Emmanuel who gave me this slide. But essentially, what we know is that if you getting 3 A's at A level is good, right? This is at the time when there wasn't an A star. So this is the highest grade you could get. And the percentage of children getting those grades are, so Asian kids match the white kids at 11%, black kids not doing quite so well at 5.5%. But these are the children who then go on to get into medicine. Just to say, having your A-levels really isn't enough. A-levels from A-levels, anyone can do that. You've got to do all this other stuff as well. So the very fact that they get into medicine at all, or dentistry in this case, is pretty phenomenal. You know, they have to do loads of extra work, and they have to show that they've solved world peace. And last week they sorted out Northern Ireland. You know, they have to do so much stuff to get in. Applications accepted. Well, and again, look at that. This is when you lump everyone together, it's not so good, because within that BME will be a lot fewer black and a lot more Asian. Yeah. So sorry about that, but these are a bit old. And this is one of the reasons why you need to try your hardest to kind of disaggregate the data so you can really see where the issues are coming. Anyway, fewer people from minoritized ethnic backgrounds being accepted. Anyway, but if you can get in, you've made the grade, and then you do all the work and everything else, all very busy and it's hard and etc., etc. But then you qualify. And if you qualify, then you really, the standard deviation between the very best and the very worst doctor is really quite small, which is different, say, for example, with nursing staff, where the standard deviation is really very different, where the best nurses are like the best doctors, but the worst nurses are much worse than the worst doctors. You understand? And that's just to do with the nature of the training and reading out and blah, blah, blah. And so when you pass through, you have your annual review of competence, and this is something that happens when you're training. Interestingly, there starts to be an increasing separation. So if you're from a minoritized ethnic background, then you are deemed as not so good much more often than if you're a UK white graduate. So UK graduates, if you're a minoritized ethnic background, then you're more like, you're 18% are deemed unsatisfactory, compared with, say, about 13% of the white graduates. But if you're from an international, if you're trained in international medical school and you come to train in your speciality later on in Britain, then look at that, you are twice as likely to be deemed not so good. And that might be for various things. We don't know why. It might be because of people's accents, culture, who knows? People give all sorts of reasons, but no one really does much about it. And when it comes to postgraduate specialty exams, so this is your membership exam, really, really important. They're really hard. People work up, you have to spend loads and loads of money to do them and whatever. I'm sure you have a similar thing. When you look at that, again, the people who pass, if you are black, it's actually about 79% of UK white graduates pass, compared with 66% of people from ethnic minoritized groups. And if you are an international graduate, then only about 45% pass their specialty exams. And in fact, more recent evidence is that 79% of white graduates pass UK white graduates, compared with about 72% of Asian graduates, compared with about 62% of black graduates. This is UK. What's interesting, back to that thing about socioeconomic factors, if you compare affluent black graduates, black trainee doctors, to black trainee doctors from less affluent backgrounds, there's a significant difference. So it's like 68% of the affluent doctors, black doctors, are more likely to pass their postgraduate exams, compared with 59% of those from less affluent backgrounds. And then you get onto this, very importantly, GMC referral. So the GMC, General Medical Council, this is our regulatory body. And basically, if you are from a white grad, if you're a UK white graduate, then you're only about 4% get referred. Twice as many people from minoritized ethnic backgrounds get referred, and particularly if you're an international medical graduate. It doesn't matter how long you've been in the UK, by the way. You could have been, I have friends who came, a year after they did their medical student training, and they've lived in the UK for 25, 30 years, and they're still more likely to get referred. Doesn't matter how well they've assimilated. When it comes to career progression, again, there are significant disparities where you see, if you look at this, so if you look at all doctors, about almost it's almost a half are from minoritized ethnic backgrounds, just over a half are white. Look at consultants. When it comes to consultants, because consultants is when that's what you're aiming for in many cases, it starts to drop. So only about less than 40% are from a minoritized ethnic background, whereas we're talking it's now kind of 56%, 57% are white. And when it comes to professors, 70% are white, yet only 16% are from minoritized ethnic backgrounds. I just want to remind you right at the beginning, look at that. These are kids who all had the same level of educational attainment, all able to do all those extra things, all able to be personable, because you have to be personable and you have to be able and you have to be clever and you have to have all those accoutrements, and you also have to have all the skills of being confident to go and give talks, etc., etc. So they all have and had these characteristics, yet what's going on later on? And ultimately it results in the pay gap. What does it look like in practice? What it looks like in practice is this. So this is Dr. Manjula Arora, and she was suspended for dishonesty. Now, probity and honesty is crucial in medicine. It's really, really important, because what you need to know is when you say to your house officer, what we're okay, listen, we need to know what Mr. Jones's full blood count was. If the house officer says, yeah, it was 10.2, right? And you sort of think, hey, are you sure? And then you find out that the house officer hasn't done it. It's really important, because you might make decisions based on what you think the full blood count is when you didn't know what it was. So probity is really important, and it's drummed into you all the way through medical school, right? Anyway, so Dr. Arora, who happens to be, you might see that she's Asian, she's South Asian, she's an international medical graduate, but been working as a GP in the UK for a good 20 odd years, 25 years, something like that. And she was working for a kind of GP agency, like called Mastercall. And she'd not been working there too long, but she needed a laptop, and she had asked for a laptop, and she emailed the IT department and said, I've been promised a laptop. So they checked this, and it turned out that, in fact, actually, where's my phone? I'm going to read this to you, because I think it's probably useful for you to see what they said. So she said that she'd been promised a laptop, and the medical director, in fact, had said, because she talked to him about it, and he'd actually said to her, we don't have any laptops at present, but I will note your interest when the next rollout happens. So when the call came around about, what do people need in terms of IT equipment, she said, oh, I've been promised a laptop. Anyway, can I ask a question? Do people think that her saying that was dishonest? You might say it's maybe a bit misleading if she'd done it on purpose, but if she'd done it on purpose, maybe it was. But anyway, she hadn't done it on purpose, but she thought she'd been promised a laptop, right? Anyhow, amazingly, the organisation that she was working for decided that this was dishonesty and referred her to the GMC. And I have to tell you that being referred to GMC it's just horrible. It's horrendous. If a letter comes through from GMC, it's either because you owe them your annual fees, or if a letter comes from the GMC, it's like, oop, what does that mean? Because it means a whole world of pain. I was referred to GMC once after sectioning a patient, and he complained. He complained because he thought I was in league with Dr. Antonio Banderas, the man who had made his wife pregnant from King's Hospital. And so he referred me to GMC. Now, actually, you laugh, because actually it wasn't. Just say it wasn't true. Those of you who didn't laugh, it wasn't true. I was not in league with Dr. Antonio Banderas. But nonetheless, when that letter came through, it was horrible, because what you then have to do You have to go to your medical director, so been referred to GMC. It has to be investigated. You have to get people to write things for you saying this person is of good character. They've never done anything like that. They don't know Dr. Antonio Banderas. Blah blah blah. It's highly inconvenient, and also it's kind of anxiety provoking for the whole time, and it goes on for weeks. And that's even with something that's a ridiculous thing, right? Anyway, she gets referred to GMC. And then the GMC investigates it, and then they take her to a panel. So it should have been stopped, that didn't stop. They take her to a panel. She's sent to a fitness to practice panel, and she was suspended. She was suspended. Incredible. Now, compare that with, this is Dr. Luke Morgan Rowe, who, is a nice looking chap and all the rest of it. He was working as a radiologist, actually. In fact, I'll read you his story as well. So when Dr. Morgan Rowe was working as a radiologist, you can look him up. These are in the public domain. And he was working as a research registrar. And as a research registrar, he was required to see a number of people and get it signed off by his line manager, the professor who was conducting the study. And what Luke Morgan Rowe did was, because he was a bit strapped for cash, because you get paid for all the people he would see, is that he started filling in the forms himself, and he photocopied the signature of the professor and put it onto a timesheet, and then was able to claim for 8 months, actually, was able to claim quite a lot of money for people that he hadn't actually seen. So I need to ask you, is that dishonest? Yeah, it is dishonest. In fact, I would go so far to say that that might even be fraudulent. And as we know, fraud is actually a criminal offence, right? Anyway, so as I say, just with Dr. Aurora, she was referred within a few weeks. Some years after doing this, so it was noted about a year later, someone said, oh, there's a few discrepancies here. And he was referred to what's called the NHS fraud service. He's referred to the NHS fraud service, and they look into it, and they decide this is a criminal offence, and he was, sent for prosecution. In the meantime, he's continuing with his career and blah blah blah. Eventually, he gets referred to the GMC, and last year, just after Dr. Manjula's case, he was taken to GMC, and the GMC also suspended him, actually, which is the right thing to do. They suspended him as well. But look at these two people. They were both suspended for a few months. I think suspended for just under a month. He was suspended for just up to 6 months. They got the same treatment. But look how low the threshold was for Dr. Aurora. Okay. Anyway, there is guidance about this. The GMC have now acknowledged that basically how well you do in medicine depends on your race and ethnicity. And they admit that there are systematic differences in outcome when you group cohorts by their protected characteristics and socioeconomic background. But the biggest gaps in attainment are linked to race. It's not how clever you are, it's not how funny you are, it's not how brilliant you are, it literally is your racial background. People have said, well, it's because, the academic ability of the students isn't so good. I think I've shown you that that just is not the case. The evidence is that once you get in, everybody is usually pretty good. If people say it's poor exam technique, that's also not the case, because if you get in, you've got good exam technique, and certainly by the time you qualify as a doctor, you've got pretty good exam technique. Maybe it's because they're a bit dull. Probably not, because if you got in, you can't be that dull. In fact, Catherine Wolfe, who works down the road, says this. She works at UCL. These are the important things. It's something about your learning environment. Learning is a social activity. There's no point having minoritized ethnic doctors or medical students, and saying, go off and learn this. What happens with everybody else is that people often learn in a group. You've got to be able to encourage people to learn in a group. Fitting in, expecting people to fit in with you is not always the way forward. You've got to make the environment so that people feel able to be part of the group. unease in giving feedback to students from different backgrounds. You need to give people feedback anyway. These are some of the facts that have come out. And then sometimes there might be bias in the kind of assessments that we give to people. And very importantly, there are low expectations. So if someone doesn't do something so well, you don't feed back to them that it's not so good. And you think, well, I'm not expecting much from them. They carry on doing the same thing incorrectly again and again and again, because you haven't actually told them the right thing to do. And then you think, well, look at that, they're just not very good, are they? Of course, because you never taught them. And then also, you know, there is a thing that if you're from a minoritized ethnic background, you do feel like you've got to work twice as hard to get the same recognition. And I think Dr. Aurora, Dr. Luke Morgan Rowe case shows that actually, you know, you get far less give, and there's a lot more expected of you to show that you're good. There's guidance from the BMA, and there's a charter for medical schools, and I think this would be useful for any teaching establishment. And this was brought, when they looked at this, they found that a lot of the Black kids who were going into medicine were finding that people just made lots of assumptions about them. Number one, that they were poor. Actually, there's quite a lot of affluent Black kids going into medicine. But the Black students were separated out. They were treated very differently. That people didn't bother to do things like, you know, find out how to pronounce their name and just make fun of it and then shorten their names, things like that. And this happens with lots of Asian kids as well. And sometimes making openly racist remarks, not okay. But there are things that you can do. There's a code of conduct, which you can, and there is guidance and, you know, an access to trained supporters, something about active bystandering and monitoring. And then reviewing existing procedures to make sure that students know how to complain if there's a complaint. Because one of the things is that people feel like, I'm on placement. We have placements. I'm on placement for 6 weeks. This doctor is treating me terribly. What's the point? I'm going to be leaving anyway. Or if I say something, he's going to mark me down. Okay. So you've got to make sure that particularly you talk to people who are organising placements to ensure that they know the expectations of the kind of behaviour they have. And just to say that, you know, one-off EDI training is not enough. It's got to be little and often. And you have to expect that people are going to be clumsy, not going to get it right first time. But it takes practice. You've got to get in the habit and understand what the issues are, so you understand how your inner prejudices that you might not be aware of might affect your decision making. And then there need to be, and these are the things that they say, support individuals, have robust procedures and processes for reporting and handling complaints, mainstream equality, diversity, inclusion, which is great that you're having a day like this. And certainly if there is racial harassment on work placements, especially, you've got to address it. Anyway, and I shall leave you there because I've been talking for too long. But anyway, thank you very much.
I think we're out of time. I also think the day's done now. Thanks very much, Lade. Your thoughtful and insightful presentation. Lade's going to be staying with us to the break, and then she's got to rush off to other duties. So I'm now going to ask Jerry to come up and pop his slides up, and he's going to be looking at the first part of the UrGEnT project, which is systematic review, looking at harassment and bullying in undergraduate education across the entire rehabilitation professions. So,
thank you very much, Steve, and thank you very much, Dr. Lade Smith. I think you are going to see that there is a lot of overlap between the medical perspective and what we have found in the last couple of years with our work. So when we started, we knew from discussions with students and from personal experiences that there was a need for change, but saying that we didn't know exactly what was the evidence. So that's why we started with scoping the literature and doing a systematic review. So in this presentation, we will talk about discrimination, bullying and harassment, and we'll talk about chiropractic, osteopathy and physiotherapy professions. And we will look at the evidence, international evidence, not just in the UK. So a lot of what I'm going to talk now, but also in my next presentations, is likely to be a bit upsetting. At least I have found that extremely upsetting in the last couple of years, looking at the evidence, listening to students' experience during training. And I anticipate that you might find that a bit upsetting. And in a way, if I dare say so, I hope you will find that upsetting, because this is really the call for change. But what it isn't, it's not about blaming or shaming anyone. It's really a wake-up call for us to take actions and to make a much more inclusive environment for our students. If we want to have better representation of the general population in our student body, we need to make sure that their experience during training is positive. At the moment, it isn't. We need to change that to make sure that if we manage to have a more diverse population in our students, that they have a positive experience and they manage to complete their course. So Dr. Smith already talked about that, so I'll go quite quickly about that. But we could start with looking at our society. Is our society fair? And we know it isn't. If we look at very high level of evidence like the Daily Mail, we can see that, we know that there is a pay gap, massive pay gap for women. And this is something that is not really, we are becoming much more aware. It might be a little bit improving, but not as fast as it should be. We know that based on the color of your skin, the treatment that you are going to receive, including from the police force, is going to be different. And that was obviously epitomized by the Black Lives Matter movement in 2020. Even though we are a very rich country, we know that people needing to have access to food parcels is very high. And obviously that was prior to COVID and to the NHS crisis, which has even more increased. Depending on your religious beliefs, if you are from a minority group, here it's about the Jewish community, again, you are much more likely to have discrimination. If you suffer with, or if you live, with a disability, again, you are much more likely to face discrimination and to have poor experience in life. So we know our society is not fair. But what does that mean in health? Well, I think it's been already quite well explained that, regarding health, there's a huge inequality system that is there in the UK, but also in other countries. One recent example that you might have seen in the press was about the use of oximeters. And oximeters were developed and tested mostly on white skins, and they lead to having wrong readings for patients who are Black. And that is not something that is discussed a lot, and therefore healthcare professionals are likely to read, the oximeter reading and take that up for, an objective value when we know that it's not going to be as efficient. And oximeters have been used a lot in the past, but even more in the last 3 years because of COVID. That has led the NHS to make changes to make sure that then we have better ways of trying to understand, oxygen levels. We also know that depending on your background, your ethnic background, your likelihood of death when giving birth is much higher. So here you might not be able to see very well, I apologize for that. But if you were born in the UK or if you were born in Jamaica, you are 30 times more likely to die when you give birth in the UK. And we've talked a lot about that, with some changes in Scotland, as I'm sure you're aware, for patients who are trans, and their access to care is also very slow and they have very negative experiences. So whatever your background, if you're not from a privileged background, you're very likely to have a very poor experience, poor outcomes, and shorter life expectancy. So depending who we are listening to, we have a problem or we don't. Again, Daily Mail, we say we don't have any problem. There is no evidence of institutional racism, when at the same time the head of NHS race body describes that there is institutional racism in the UK. So it can be a bit confusing depending what sort of source we use to look at that. But I think the evidence is quite strong to demonstrate that there is a huge problem in healthcare in the UK and we need to make a change. This report was published by Stonewall probably 3 or so years ago, and that, for me, what led this project to start. I'm a gay man and I had difficulty during my undergraduate training because it was very difficult to know how to place myself and if I should disclose I was gay and all of that, but that was 20 years ago. And when I read that report, which was 3 years ago for all UK universities, and seeing that it was exactly the same 20 years later in the UK, and the experience was still very bad, I thought, oh, I need to do something about that. I started thinking, oh, I could do a small focus group with, osteopaths or students who are gay, and then it became much more, discussing with colleagues that it couldn't be just about one protected characteristic, and we're going to talk about that a bit later. But that really was the wake-up call for me, thinking I had a poor experience, it's the same now, we need to do something about it. So if we try to understand a little bit about our profession and we look at the demographics, we know that it's difficult to understand who we are. So the demographics is mostly at the moment, people decide not to answer questions about demographics. There's probably a reason about, I'm not sure why I need to disclose that information. What are the risks of me disclosing whether I have a disability? And that leads to us not really knowing who we are. So 55%, for example, of the profession decide not to disclose their sexuality. We know that we have a huge underrepresentation of people with disability in the profession. We're around 2 to 5%, when in the general population it's around 20%. And there might be, well, we know there are barriers to disclosure, and we will talk about that later with the survey that we did with students, which we have faced similar issues with the students. So that is also a problem, that if we can't access and understand who we are, then it's even more harder to understand whether there are attainment gaps in the students. And in the profession, there are not many of us, but we are there. There are people with lots of different protected characteristics, either based on their sexuality, their ethnic background, their age, and all of that, their disability, and we are here. It's just that we don't really see us because the data is not really providing that. So all of them are osteopaths, and they gave me their consent for me to use their picture, because people who are from underrepresented groups are, they are activists in a way, for most of them, and they're willing to help and to have this message coming across. We live in a society where some of us have power, and this power comes from the privilege. And this privilege, we didn't earn it. It's just where we were born, from which family, which neighborhood, and which ethnic background, which country, and all of that. But it's not because we did better than others, not because we worked hard having this privilege. And the lens we took for this work was really about trying to make a change, and it's around social justice. And it's this form of allyship and working together towards this equity. And we know that not all of us have the same power. And what can we do to try to make the balance right? A very simplistic model, but which I think can be helpful for people who are less familiar with this topic, is the coin model. This coin model describes our society, and we have an unfair society where some of us have privileges and we tend to be at the top, where we have advantages that others don't have, not because we did anything in particular, just because of who we happen to be. And others, then we are going to be oppressed, and they are going to be at the bottom of the coin, and they are going to have disadvantages. It's simple because it seems to be that you are either at the top or at the bottom, when obviously we have lots of coins in our own pocket. I'm white, I'm a man, I'm a cis man, I'm gay. So all of that is giving me some, I'm on the top of the coin and I'm the bottom of the coin for some of that. And this is, what we call intersectionality. And that's why, this project had to become much more than just looking at what is the experience of LGBT osteopaths or LGBT students. Intersectionality is a metaphor to try to understand the multiple forms of inequality that people face. And it's really about the obstacles that people are going to have based on lots of different characteristics. I've just listed a few here based on their gender, their race, their class, their sexual orientation, their physical ability, etc. And all of that together is going to give us an experience and some form of power or oppression in our society. So, as Steve already said earlier today, it's not about trying to understand where we are. We know that we are in a place that needs change. It's really towards transformation. We want to have a change, and that's what I'm hoping that this forum today is going to lead to. So for this systematic review, we used a lens of which is called critical theory, which comes from psychology and literature. And it's really this idea of trying to assess and to explore the level of power and who has power and what are the consequences of that. And to do this, we used a method which is called critical interpretative synthesis, which allows to bring both quantitative and qualitative methods all together and to try to understand a little bit what is out there. So we published that paper last year. It's in open access, and the team was Andrew Macmillan, who was the first author, David Hohenschmidt, Valentina Migliarelli, and myself. So that has already been discussed, what discrimination, bullying, and harassment are. These themes sort of overlap, but are a bit different. So discrimination is really the abuse or humiliation that people are going to face because of their personal characteristics. The bullying is going to be the negative behavior that either individuals or groups are going to do to victimize or harm others. And harassment are the behaviors that are perceived to be abusive, humiliating, or hostile. So when we screened the literature, we found 400 recalls, and we had 17 that were included. So that was at the beginning of the project. What we found was that most of the literature was from physiotherapy, and mostly from the UK. There was one paper from chiropractic, nothing in osteopathy. So that's where we were when we started a couple of years ago. We knew nothing. What we found was that in the UK, a quarter of physio students reporting having experienced bullying, and 100% based on one publication of the Nigerian physio had faced bullying. We have to be careful because the UK data is from just one institution, small sample, so we didn't know much. And all of the publications report that there's a very likelihood of underreporting because it's difficult to disclose. What's the point in disclosing? And we're going to see that's a theme that comes often is, yes, it happened, but it's not going to change much saying that, so I'm not going to bother. Almost 2/3 of the incidents were from a member of staff to a student. And again, because of risk of retaliation, most of the students decided not to disclose. So they might have said that in a survey, but when that happened, it wasn't disclosed to the institution. And the behaviors that were reported range from just having some sort of when I say just, I'm not trying to minimize that, but having unsupported behavior from staff up to sexual harassment or aggression. The attainment gap, and attrition rates were much worse, mostly for students from minority ethnic backgrounds and living with a disability. And that was in the UK physiotherapy. There was a very strong cis heteronormative culture that was often masking humor with a bit of banter, and we make jokes, and that's okay. But what we found in our systematic review was that there was no data, or there was a lack of data on the experience of LGBTQ+ students. And sexual harassment, and there was a culture of gender discrimination. One thing that came, for example, was that female students decided to desexualize their appearance during training. Another example that really struck me when doing that review was, for example, during placements, female students were asked to go and make tea for everyone when the male students were discussing with the clinical tutor their presentations. So again, the learning time was diminished by your gender. Because you were a woman, you were expected to go to the kitchen and make tea so that the men could discuss among themselves. And that's the level of training we're talking about in the UK nowadays. So we know that there is a widespread discrimination, harassment, and bullying within manual therapy education. And we knew at that point that we needed to do more research but also to do more research to understand the intersection, because a lot of the research that was out there was looking at one characteristic, ethnic minority or sexuality, even though it wasn't really, there was not much data on that, or disability. And that led to a need really to try to understand a bit more the experience of students, but also how the sort of intersectionality was impacting or having an effect on their training. And what was quite striking was that there was no data in osteopathy worldwide. So that led us to then do the work that we're going to present later, the survey and a series of focus groups. I went much quicker than I anticipated, so I'm sorry, but I'm done.
Gives us a great opportunity for the audience to ask questions of Jerry, but also of Dr. Smith as well. And we've got about 10 minutes for questions, so I'm happy to. Jerry, would you turn on that mic for me?
Yeah.
Yeah. I'm John to join us then. I'm happy to take questions from the floor. Yeah, Jerry, can I?
I can shout. That's the official one, sir. All right, thanks, Jerry.
Jerry, come back. I'll do the mic. You stand there. I'll do the question.
Actually, do you want to swap these ones?
My question is for Dr. Smith. I was curious to see the kind of disparity in international graduate sort of exam pass rates and outcomes in medical education. And that's something that's beyond just race and ethnicity as presented in the statistics you shared. I'm curious if you could share more about your perception of xenophobia in
Sure.
British medical kind of training and education institutions. Thank you.
So that's, what's this one? No. That one? No. Oh, okay, it's one of these ones. There we go, that's better. So that's actually a really, really good question. And again, it's one of those things where, because everyone used to just lump everyone together, it's only now that people are starting to see that there's something extra going on. So what's interesting is that it's not simply about the colour of your skin. If you're an international medical graduate, there's also something about accents and being able to speak English at a certain kind of level, etc. Now, of course, so just for everyone to know that if you are an international medical graduate, it doesn't matter where you come from, you have to pass an exam that shows that you have medical academic level of English. And that's not just a written exam, but a verbal exam as well. So actually, the stuff that people say, oh, I can't really understand what they're saying, it's just not true. The fact is that people do have the ability to conduct themselves in medicine as well as anyone else because they passed that exam, and it's a really hard exam to pass. The xenophobia, it's really hard to say. We don't know exactly what it is yet, but it's likely to be related to the same kind of prejudices that exist in our society generally. And it is that thing of othering people because they don't sound the same as you. There might be something about cultural mores as well, and people from different cultures and people being anxious about someone being not like them. And that may, so the biggest group of people who are international graduates are actually coming from South Asia, and primarily Indian doctors still, actually, although interestingly, India's doing so well now that a lot of Indian doctors are actually going back to India because it's a better place to work. You can earn more and you have more respect and things like that. So we don't know exactly what the reason is. It's definitely some xenophobic factors, and people are now starting to look into it. It's likely to be related to things to do with people's accents, things to do with people's culture, and differences in the way you conduct yourself.
Jerry, what you were saying about fear of retaliation, I'll show you my phone. Yeah, which one? Is there anything that shows to help with that issue? Because I know that in clinic, even we're relating it very much to our institution, the anonymous feedback. I know that almost every time it comes up at the end of the term, a lot of students are incredibly anxious to fill that in, just because we're asked to describe specific events and give very specific stories and things get into. So, is there anything in the literature that shows it's been helpful to help that issue?
Again, a good question. So I will touch a bit on that during the focus group presentation, where some students discussed that. I guess there are quite a few elements. Sorry, I'm thinking what's trying to answer, but there are a few elements that spring to my mind. One of them is the culture within the institution. And there's an issue that came up quite often about silent discrimination and the fact that peers do not step up. The acting, basically training maybe that is lacking, but this idea of banter or a joke being made which is racist or misogynist or whatever, and others just either laughing or not saying much. That doesn't really create an environment where it feels safe to complain or to talk about that. Another issue is that whilst most institutions will have procedures and policies in place for complaining and all of that, they are quite obscure and people don't really know what they are, and they don't know exactly how they can access them, and also what would be the outcome, what are the risks, the risk of retaliation of that. And having been on panels, I know that the students are going to be extremely well protected, but the students don't know that. So this is something that do exist, but is not clear, and that's definitely one of the outcomes that I think we will take from today is about working on policies and making them much clearer to students. Going back to your question specifically, is there anything about the literature? As far as I'm aware, not really like that. The main thing that came in the literature was that it's a recurrent thing. It's always the same problem in lots of different professional institutions, is that they are stuff, but it's in sort of a corner. No one really knows about that, and then it doesn't really happen. I don't know if I've really answered your question, but.
Sure.
I was just going to say about training. Maybe it's not just training staff, it's training students in allyship and active Boston as well. Right from those concepts and better culture of the education, that we're all there to look after each other and stand up for each other and support each other where it's necessary.
Yeah, one thing that came up too is that students from underrepresented groups are the ones who are actively seeking training, and they are doing that by themselves. So either by their own experience, and then they try to understand other people's experience, or because they have met something in clinic and they don't have the training, so they actively try to get, which means that then they became sort of advocate, but not by choice, because no one can step in and provide that, that knowledge. And this lack of training for these, the faculty, but also students, is definitely one issue to consider.
It's great to hear these questions, which really reflect the workshops. We've got planned later, some of the data coming up. So we should have a fruitful day. We've probably got time for one last question. We've got 3 minutes left in the schedule. Thank you.
So I was just wondering, are there any particular themes that have emerged either in research or anything, what happens within the media and how that's creating discrimination? So, for example, quite a big topic at the minute is to do with Russia and Ukraine. So, any biases or discrimination towards whether that's patients from a Russian link or students and what they're facing from patients or other students' perspective.
Yeah. So that's again a really good question. Without a doubt, there's very good evidence that what happens in the media does influence people's thoughts, actions, etc. Because oftentimes people might not know people who are like that to have a counter to whatever the media is saying. And so it means that unfortunately a prejudice might grow, and then that might be used to discriminate against people, which is that's the last point actually. Really, everybody should be taught about this, whether you're a student or a trainer, all the way right from the start, because we have to accept that because of the structural factors, we are not aware of them. And I always say, well, let's just start with an amnesty. I think one of the difficulties with students going, as Jerry was saying, students going off and learning for themselves, is that you might actually be, learning from someone that says, you just have to cut it there. Don't give any kind of leeway to anybody who gets it wrong. And then it gets too harsh, and we've seen what happens with that when people get cancelled and things like that. And that's unhelpful too, actually, because that means that people end up not feeling like they can speak out. So we've had this now where people who are Russian background doctors who are having to hide their Russianness, and because it's okay to be Ukrainian, but it's certainly not okay to be Russian. And recently I was talking to someone who said that they think they might not have got a job because of that, but it's very hard to prove. So it's absolutely crucial that people understand how they can be influenced by these kind of external pressures, including the media.
And on a very anecdotal point of view, some of our patients are from Russian background, and so, I guess it's also being open about that and asking questions about their experience, how it's been for them, and exploring potential prejudices they might have experienced or in the last year or so. And I think this is also part of being an ally, and accepting that it's our role to, as healthcare practitioners, to look at the whole context of the person.
Okay, that brings us to the end of the session. I just